Good morning, everyone, and welcome to this webinar on smoking in the home, new solutions for a smoke-free generation. I'm Hazel Cheeseman, I'm Director of Policy at ASH, and I am going to do a little bit of housekeeping at the beginning and talk you through the sort of background to this report that ASH has produced, and then introduce our excellent speakers that we have for the rest of the morning. So a little bit of housekeeping first of all. If you have any technical problems during the webinar, you can use the chat function, which is should be in the panel on the right-hand side of your screen, and John or Vicky should be able to assist you. So if you have any problems at all, then type that into the chat function there. If you want to ask questions during the webinar, you can use the question bar in the panel on the right-hand side of your screen and send as many questions as you like. We're going to be doing Q&As mostly at the end. The other people participating in the webinar won't be able to see your questions, but we will at this end, and we'll make sure they get put to the speakers. We are recording the webinar and it will go online, so you should be able to share it with colleagues and others who are interested. And you can see the agenda. You should be able to see the agenda up in front of you on your screen of our various speakers this morning. I will introduce them as we go through this morning. Right, so without further ado, I will just, this is just to remind you of how to do the questions. We are certainly keen for lots of participation this morning, so please do think of lots of questions and send them to us. Right, so to introduce the report, give you a little bit of background to ASH. Not all of you may be familiar with us as an organisation. So we were set up in 1971 by the Royal College of Physicians with a mission to eliminate the harm caused by smoking, and that's what we've been doing since the 1970s. We're predominantly funded by the British Heart Foundation and Cancer Research UK, and we also have some project funding from the Department of Health. So why are we talking about smoking in the home today? You know, why are we looking at sort of different options as to how we might further reduce smoking, particularly in the context of this graph here is smoking rates for those over the age of 18 across the UK, and you can see that smoking rates have been steadily falling over recent years, and progress has been really quite positive. So why is it that we are taking our time to try and think about new ways that we might be able to reach smokers? Well, this is one of the reasons. So this graph here shows the smoking rates among different professional groups. So the top line there, people who are most likely to smoke in routine and manual groups. And then that bottom blue line is the managerial and professional occupations. And there is clearly a very big inequality between social groups in relation to smoking. And that's driving all sorts of inequality, so particularly health inequality, so responsible for half the difference in life expectancy between rich and poor, but also in income inequality and inequalities linked to taking up smoking, which become much more common if you are born into communities where smoking is more common. And this next slide again looks at some of the issues around children and the impact of smoking in the home and among families. So I've taken this data from Scotland because it's nice and clear, but the same is true of England and other parts of the UK. So what you have is these light blue bars, which are showing the number of children in each of these indices of deprivation who have a parent at home that smokes. And then the dark blue bars are the number of children or percentage of children who are exposed to smoke in the home. So you can see that you've got lots of harm-reducing behaviour among different socioeconomic groups. That lots of parents who smoke are taking their smoke outside and not exposing their children to smoke in the home. However, if you are in the most deprived groups, you're not only most likely to have a parent who smokes, but you're much more likely to be exposed to smoke in the home. And this is clearly a real cause of inequality from the very start of life, that children should be exposed to smoke in the home and all of the health consequences that can come with that in terms of poor respiratory health and the increased likelihood of taking up smoking as you become adults. So this is why we think we need to have a look at how we might tackle smoking in the home. Clearly, we need to start thinking about new approaches to tackle these entrenched inequalities between social groups in relation to smoking, and perhaps locating what we do, in a more place-based approach, closer to where smokers live, taking it to their front doors, making it easier for them, is a more effective way, or could be another tool that we can use to help reduce smoking rates and close these inequalities and protect those children in the most disadvantaged households. There's also really big opportunities that are potentially not being realised as fully as they could be in every local authority. The location of public health into local government is not new news anymore. But not all of those opportunities from being in local government where strategies around housing, for example, are being developed are necessarily being exploited, and something we should certainly be looking at for the future. And some of these models that we have that are in place have been in place a long time, the kind of more traditional ways of reaching smokers. Maybe we need to start looking at new approaches that can be more sustainable, can build better partnerships with public health and other parts of local government and the wider sector. So just a reflection really on where the gains are here. And I think the social impact of smoking is so widespread and the social benefits are so limited that for the public sector, there's very few professional groups who wouldn't have an interest really in seeing smoking rates fall. From the fact that it can put thousands of pounds back into a household income, through to the impact it can have on fire safety, and of course the health benefits from the start of life all the way through the life course, means that there's a real benefit to a whole range of professional groups from intervening and reducing the rates of smoking. So here we talk about the fact that it's the leading cause of preventable illness, that smoking in the home has an impact on child health, the links to fire fatalities, which we'll hear more about later in this morning, the impact on neighbours and others, the impact on disposable incomes and the ability to meet your payments in relation to rent and other things, and of course the increased maintenance costs in the home. So there's a very wide-ranging case for reducing the rates of smoking, where health, certainly for a public health charity, is our kind of primary objective. But there are all sorts of other really great reasons for reducing rates of smoking and reducing the exposure to secondhand smoke in the home. So just a few words on how we developed the report. So smoking in the home, new solutions for a smoke-free generation. We didn't produce this on our own. We had lots of input from professionals, from public health, from housing, environmental health, trading standards, fire. And some of those people who contributed to the development of the report, particularly Lee Sugden, will be speaking today. We also made sure that we went out and engaged with tenants in both the private and the social sectors to make sure that we'd heard from people who were smoking themselves, but also were impacted by their neighbours smoking, to think about what it would mean to take different policies forward in relation to reducing smoke in the home. And we also looked at the evidence and national data sets. And then we published the report, and while not all of the headlines of the report were necessarily misleading, there was a great deal of coverage that related to the fact that we had perhaps called for a ban on smoking in the home. I should have looked up before we started the presentation how many times in the press release we said we're not calling for a ban, but it was certainly more than once. But what I think is really interesting about the media interpretation of a report that is not and was not calling for a ban on smoking in the home is that when you start talking about smoking in the home, that seems to be what people hear. They hear that you're talking about whether it's a good idea or a bad idea to introduce a ban in relation to smoking in the home. But the report is much more sophisticated than that. It looks at a whole range of options about how we can reach smokers in different ways in ways that I think may well be more effective than a straight-up ban, and looks at how we can really broaden the number of people who might be engaged and interested in addressing smoking, focused around people's homes. So just a quick overview then, I suppose, of the things that we actually are calling for. The report looks a lot at local leadership, at the role of local government in the strategy setting and in taking forward the partnerships that could help deliver more support to smokers closer to where they live. And the emphasis on partnership is absolutely key, that we want to see a much wider group of professionals. You know, we have thousands and thousands of professionals who are going into people's homes every day and could really be bringing those messages very effectively to smokers about why it is that abstaining from smoke in the home or making a quit attempt could be really valuable to them. So this idea that we need to mainstream the idea of brief advice on smoking with a much wider group of people is also really, really important to the report. And identifying where the appropriate places are to engage tenants in discussions about smoke-free settings. So this isn't about saying smoking should be banned everywhere, but about looking at those environments that could really reinforce the idea that quitting is a normal behaviour, taking your smoke outside is a normal behaviour, and smoking inside no longer is. These are the 13 overarching recommendations in the report, and we're going to explore some of these through some of the presentations today. So we're going to look at how we might bring support closer to people through working more closely with landlords, how we might engage with different professional groups to put support more closer to people in the home. But I think what's really important from looking at all of these recommendations is that they're not about a particular type of housing or a particular type of landlord. They actually relate to all forms of housing, largely speaking. Private rented, socially rented, and that's deliberate. Smokers live in all of these types of housing, and we need to find ways to reach all of them. So what we want to achieve, I think, is this idea of a shared ambition across health and housing to reduce smoking. We really want to look at how we can up the rate of quitting in some of these communities where smoking is common. And our next speaker is going to talk in much more detail about what we found in relation to some of our more deprived communities. Clearly, with an overarching aim of reducing smoking-related ill health and death, both among children and among adults, and also thinking about how smoking can contribute to the economic prosperity of our communities. I just wanted to say one last word on where we're taking the report next. I know it's a bit unusual at the beginning of the presentation, but just to give you a sense of where we're going. So there will be a prevention green paper that we expect from government. They've promised to do one in the next year, hopefully before the summer. And we will be making a strong case that that prevention green paper includes some specifics around smoking in the home. We're going to be developing a toolkit to support local authorities develop their own strategies in relation to smoking in the home. And we're going to be publishing some new analyses that are relevant to this agenda, so particularly looking at the impact of smoking on social care and the impact of smoking on tenants' incomes. We're also going to be working on some guidance to enable landlords to have a more consistent approach over smoke drifting from one neighbour's house to the other, and try to give some more guidance to landlords on how they might be able to support and manage those situations. And working with organisations in the private sector to support a more consistent approach to tenancies in the private sector that particularly emphasise some of the harm reduction opportunities of e-cigarettes, whilst reinforcing the kind of standard norm in the private sector around smoke-free indoor spaces. So that's all I'm going to say about the overarching kind of concept of the report. And the presentations we have today are to kind of add a bit of flesh to that bone. So we're going to start with Dr. Sarah Jackson. Sarah is a senior research associate at UCL. And Sarah worked with us to do some analysis of their long-term study, the Smoking Toolkit study, to look particularly at the differences between different tenures of housing and what was happening in terms of smoking rates and what was happening in terms of quitting behaviour. So we're just going to try and hand the screen over to Sarah. Sarah, I think you're good to go. We can see your screen, Sarah, so over to you. Sarah, can you hear us? Small technical problem, maybe? We can see your screen. You need to enter your audio pin, I think, Sarah. I think that seems to be the problem. Sarah, can you hear us?
Want to switch to me?
Lee, yes. Should we do that? Should we hand over to Lee and come back to Sarah then while we sort Sarah's audio out? Could you do that, guys? Apologies, everyone. These things never run completely smoothly. So we will hand over to Lee. Lee, I need to give you your proper introduction. So Lee's the Chief Executive of Salix Homes, Housing Association in Salford. So we have enormous thanks to Lee because he gave us so much input in the development of this report over the last year and continues to do so. So Lee co-chaired the report with Ruth Tennant, who was the DPH in Leicester and has recently moved to Solihull, which is unfortunately why she's not been able to join us this morning. And Lee is going to talk a bit more about some of the work that I guess kind of got you involved, I suppose, in this agenda a bit, Lee, in relation to the use of e-cigarettes in Salford. So I'll hand over to you now, Lee, as we have your slides and your audio is working.
No problem. Morning, everybody. This is a first for me, talking into a phone while presenting to 90 people. So I hope I do it justice. Thank you very much, Hazel. It's great to be able to talk a little bit about the project we did in Salford called Swap to Stop. Before I talk about the project itself, it's probably just worth reflecting on sort of why I got involved in this project. So I work for a housing association in Salford, and within Greater Manchester, people are probably aware we have a regional mayor. We have Andy Burnham as a mayor, and we also have the health budget devolved to Greater Manchester. So there's around £8 billion worth of resources that are devolved to Greater Manchester, and that has led to quite a sort of an intensive investment in thinking about how the local health economy can better use those resources to get better outcomes for the people who live here. And one of the priorities for the Greater Manchester Health and Social Care Partnership is smoking prevalence. Now, I had the fortune, actually, of attending a gathering of the great and good in Greater Manchester whose priorities are to try to help reduce illness through smoking. So it was attended by a lot of eminent people from the Christie Hospital, cancer specialists and the like. And I was there attending, representing Greater Manchester housing providers. So within Greater Manchester, the social housing providers have got our act together, and on relevant areas of policy, we try to find ways where we can speak as one. And we find that's helpful because as individual organisations, there are 27 of us, but as a collective, we represent over 20% of the population of Greater Manchester. So when you're thinking of having conversations with the likes of the Combined Authority, with the Mayor, with the Health and Social Care Partnership, speaking as one voice for 20% of the people who live in Greater Manchester carries some weight. And so it was with that responsibility, I suppose, that I attended this meeting. And it became apparent that Greater Manchester and smoking were two factors that were priorities to address the smoking prevalence. So the slide you can see here just details smoking prevalence within Greater Manchester and why it is a priority. It's well rehearsed that there are significant financial pressures on the NHS, and as well as improving health outcomes, of course, there are also potential financial benefits to the services of reducing smoking prevalence because it will lead to less treatments and less admissions in hospital. And overall, the ambition within Greater Manchester is to reduce smoking prevalence by 13% by 2020, which is a massive ask. And the challenge we were all asked to go away and reflect on was, what role can we play in the respective organisations that we were representing to step up to the mark to help support the people of Greater Manchester to lead a healthier lifestyle in relation to smoking. It becomes quite stark when, as part of the report that we've done with Ash, you realise that people who live in social housing, which the Greater Manchester housing providers represent, are twice as likely to smoke as the general population. And we've discussed the need to unpick that a little bit and to try to understand what's happening within that socio-economic group to sort of drive that kind of stark difference in smoking prevalence. It isn't something we fully understand. But the reality is it is a fact. And so I felt that if as social housing providers we could think differently about how we supported people who lived in our properties to take the action that they wanted to take in relation to smoking, then we may have an important part to play. And so it was really from there that the devolved health economy put some money behind a project to think about how we could encourage people in Salford as a pilot project for Greater Manchester. We could have a 3-month pilot to see whether giving people the opportunity to switch from smoking to vaping would encourage a different behaviour in people. And so that's where the project was born from, really. So it's important to say it was a pilot project within Salford. It was a collaboration of all the partners in Salford, so all of the housing providers, the health economy, pharmacists, public health colleagues, and we all came together to sort of develop this project. I have to say, the social housing aspect was probably the simplest part. So our role was, as well as the members of the general population, but we equipped our housing colleagues with sufficient knowledge to be able to offer, I wouldn't even call it very brief advice, it was more signposting and awareness of this project. So as they were doing their normal job, like they would have for safeguarding issues, they have a process they follow. If they were talking to somebody and it became apparent that they wanted to stop smoking, then they knew they had a pathway that they could direct that people to, which was different, that was linked in with this project. The project was monitored, so people who joined the project, it was for 4 weeks, and there were all sorts of whiz-bang techie stuff to do with CO2 levels within people to sort of test whether people were doing what they said they were doing. And it was incentivised. The financial barrier of vaping kits was taken away, so people were given the kit. Many people who live in social housing, not everybody, but many people, are on lower incomes, and so it was important to remove any financial barriers that might be associated with switching to vaping. And I think we're all very much aware that vaping is still a bit of a new thing, but we were reassured when Public Health England issued the guidance and the statement that they felt it, they went public to say that they felt it was 95% less harmful than smoking. That felt like a really strong message and something that we felt we could get behind. I remember when I was sat at that meeting, I was sat next to a senior oncologist from Christie, and I asked him directly what was his view on vaping, and he just said it's a hell of a lot better than smoking. So Public Health England really made the public image more acceptable from a health perspective, and the project was launched. Within Salford, we have this collaboration called My City Health, and a project was launched which advertised the opportunity for people to engage within the project. Like I said, it ran for 3 months. The final report hasn't been published yet. The University of Salford, who were part of the project, is still wanting to do some longer term validation of the stats. So the figures that I can share with you today give an accurate representation of the first 4 weeks. What we want to try and do is look at the 6-month quit rates and just get a feeling for those as well. So headline numbers. So we estimate there are 43,000 smokers in Salford. It's about 20% of the population. And this project in 3 months engaged with over 1,000 of those smokers. And of those 1,000, we were able to follow up with 60% of them after 4 weeks. So we lost 40% of them, which I'm sure is pretty standard. But 60% of them we were able to follow up with. And of those, over 90% were validated using these whiz-bang CO2 technologies. So what were the headlines? I suppose people want to know. Well, after 4 weeks, 63% of those who were tested had still stuck with vaping. So that's 63% of the people who were tested, which I'm sure there are people on the call who are far more aware of what sort of national statistics look like. But I'm assured that that's pretty good and pretty positive, and demonstrates something worth following up with. We did some demographic work looking at what the age range was, and I was really interested to see the numbers around here, the sort of mid-20s to mid-30s area. There was a little spike there, which suggested to me that those younger smokers were looking to try to find an alternative approach. Looked at occupation statuses. A lot of people who are unemployed, which seems to support the smoking and people who are on lower incomes or poorer demographics within society, which we want to follow up with. So the question we've asked ourselves is, do we think it's been a success? There you go. So, I mean, as a relative layperson, I think engaging over 2% of all smokers within 3 months is pretty good. I think that's pretty impressive. Clearly, we know people want to quit, and this appears to have given a route to quit that people wanted to engage with. And having, after 4 weeks, 1% of all the smokers in Salford who are not smoking anymore within 3 months seems to be quite a big achievement. So we were really pleased with that. 37% of people were still using an e-cig, and 20% of the people after four weeks were using both an e-cig and smoking, and obviously some people had gone back to smoking. So we felt it was a success. I'm very keen to see the final report. I'm very keen to explore the possibility of rolling this out across the whole of Greater Manchester, because I do think there's a real opportunity for colleagues within the housing providers partnership playing a role in signposting and supporting people to lead those healthier lifestyles. I understand there'll be questions at the end. More than happy to take any. And just a final comment, it was really good and fantastic to be able to work with Ash on developing and thinking about some of the issues in the wider report, I think it's clear it's a really far-reaching report with lots and lots of different recommendations, and I encourage everybody to give it a good read. And thank you very much for your support.
Brilliant.
I think that's me.
Thank you, Lee. That's excellent. And thank you for stepping in at the last moment. And due to my failure to chair myself well, we are running a little bit behind time. But just as we transfer over to Sarah, I just wanted to ask you a quick question. What would you say to others who said that involving your housing organisation in this kind of work is a kind of mission drift?
I would say that social housing providers are a values and a people-based organisation, and part of those values are around demonstrating and providing social value. Now, wherever I've worked within this sector, it's always been part of our core work to not just provide bricks and mortar over people's head, but to also provide, where we can, support, signposting, encouragement to people who may just need a little bit of something else extra. Now, the days have gone where we provided that support, but there are still organisations and charities and support networks out there who provide fantastic services. So, we regularly will help support people with job skills training. We see programmes to do with healthy eating. And I just see this as another opportunity for us to help and support people who want to take certain steps and actions, to take it with the support of the professionals that are out there. So, yeah, very worthwhile.
Thanks, Lee. I'll just remind people that you can put your own questions in the question bar at the side. Lee, also, we're struggling to mute you at this end, so if you're able to mute yourself, then do. Right, I'm going to, with no further ado, hand over to Dr. Sarah Jackson, who is the Senior Research Associate at UCL and is going to talk through some of the more recent research she's been doing. Sarah, can we hear you?
I hope so.
Fabulous. Okay, I will hand over to you
Great.
now. Thanks very much.
Thank you. Okay, so as Hazel said, I'm just going to talk you through some of the scientific evidence backing up this report. So what we did was a cross-sectional survey of smoking patterns in relation to housing tenure in England. So as Hazel said, smoking prevalence in England has fallen markedly since the 1970s, but remains higher in people with greater social disadvantage. So in September of last year, around a quarter of people in lower social grades, which is the blue line in this graph, were smokers. And this rate was around 50% lower in higher social grades, shown by the green line, with a sort of average of 17.7% over time in all adults in England. And the 2017 Tobacco Control Plan for England called for targeted action to address this inequality. So they really emphasised the need to see local councils identifying groups and areas with higher smoking prevalence within their local communities and taking focused action to reduce these health inequalities caused by smoking. So high smoking prevalence among people living in social housing could be an important focus. In 2016, the UK Office for National Statistics reported that a third of people who lived in social housing were cigarette smokers, compared with just 1 in 10 who owned their own home. However, it's not clear to what extent this high smoking rate stems from other factors, such as socio-demographic differences between residents of the different housing tenures. Neither is it clear how far it reflects lower motivation to quit among smokers in social housing, greater difficulty quitting, or both. So in our study, we looked at smoking prevalence, motivation and attempts to quit smoking, markers of cigarette addiction and success in quit attempts of people living in social housing compared with other housing tenures, while adjusting for other socio-demographic factors, so things like age, sex. So we used data from the Smoking Toolkit study. Now this is an ongoing monthly survey designed to provide information about smoking prevalence and factors associated with cessation in England at a population level. The survey uses hybrid random location and quota sampling to select a new sample of around 1,700 adults aged 16 and over each month. And this is designed to be representative of the English population. Participants complete a face-to-face survey with a trained interviewer. And for the present study, we used aggregated data from respondents to the survey between January 2015 to October 2017, which gave us a total sample size of around 57,500 participants. Our main exposure was housing tenure. So we looked at whether respondents owned their own homes outright, whether they were rented from a private landlord, rented from a local authority, or other. And our outcomes were in all adults, we looked at cigarette smoking prevalence. In current smokers, we looked at cigarette addiction, which was indicated by the mean number of cigarettes per day and the percentage of people who smoked within half an hour of waking. We looked at motivation to quit and regular exposure to smoking by others. In people who reported smoking at any point in the past year, we looked at the percentage who'd made a quit attempt in that time. And in smokers who'd made a quit attempt in the past year, we looked at the percentage who were not currently smoking and the percentage who'd used cessation support. So this is behavioural support, group therapy, individual therapy, nicotine replacement therapy, e-cigarettes, or prescription medication. And the covariates we included in our modelling were age, sex, social grade, region, and survey year. So any of our results account for differences between people from different housing tenures in these variables. So we had a total of just over 8,000 people living in social housing and 49,500 from other housing tenures, which we grouped together for analysis. People living in social housing tended to be female, younger, and have lower social grade, and they were more likely to live in London than people from other housing tenures. After adjusting for these socio-demographic differences between the groups, social housing residents had twice the odds of being a smoker compared with the people from other housing tenures. They were more likely to smoke within the first 30 minutes of waking, and they smoked more cigarettes per day, indicating a higher level of cigarette addiction. There was no significant difference between social and other housing residents in regular exposure to smoking by others. Now, while this might seem surprising given the higher smoking prevalence in social housing, it's likely that this is because of the way the question was asked in the survey. So people were asked whether anyone regularly smoked cigarettes in their presence. And because so many people are generally exposed to smoking, whether it's from people within the home or co-workers, people out and about, it's likely that the measure just wasn't sensitive enough to pick up differences in exposure. So what probably would have been more useful would be to test differences in exposure to smoking, looking at the number of smokers people know, but this wasn't asked. Interestingly, there was also no significant difference between smokers living in social and other housing in terms of their motivation to stop. So people living in social housing were just as motivated to quit despite being more likely to smoke. They were also significantly more likely than people from other housing types to report having tried to quit in the last year, although the difference was quite small. And they were more likely to report having used cessation support. So this is your NRT, behavioural support, or prescription medication. However, despite this extra help, they were almost half as likely to stop smoking successfully. So this study demonstrates that living in social housing is a major independent risk factor for smoking. It's clear that smokers residing in social housing are motivated and attempting to quit smoking, but they're more addicted and less likely to succeed in stopping, despite being more likely to use cessation support. So why is this the case? It's possible that social norms play an important role. So there's strong evidence that smoking is a socially contagious behaviour, with people substantially more likely to smoke if others in their social network, such as their family, friends and colleagues, also smoke. Importantly, groups of interconnected people also appear to quit in concert. So knowing someone who stops smoking increases a person's chances of stopping themselves by up to 67%. The successful Stoptober campaign is predicated on this sort of network phenomenon. And by acting to change social norms to reinforce quitting rather than smoking, it might be possible to reduce social inequalities in smoking and its associated health consequences. So how might we go about this? Authorities could target social housing with localised smoking cessation campaigns and provision of neighbourhood services. While budgets are limited, investment in smoking cessation can achieve relatively short-term returns on investment. And without action, current disparities are likely to have major health implications for people living in social housing. So in conclusion, our results indicate that social housing could be a key focus of tractable local policy and interventions to reduce smoking-related health inequalities in England.
Thank you, Sarah. That was. Hopefully, we've got lots of questions for you about that presentation that we can put at the end. But as I won't ask you anything right now because we are running a little bit behind time. So we're going to hand over to hear some of this role that local authorities can play, I suppose, in taking kind of a leadership role around smoking and housing. So we're going to hear now from Wendy Surtees and Stephen Carter from South Tyneside Council. So Wendy and Stephen are in the public health team, but they have been working really closely with housing colleagues to take a kind of strategic approach or a partnership approach to looking at smoking in the home, and we're going to hear from them now about how that's going. So, are we managed to get their presentation up? There we go. We can see it. Hello, and we can hear you, Wendy.
Excellent. Hi, everybody.
Excellent. Thanks, Wendy.
No problem. It's great that we've had this opportunity really to share with you today an update on a joint piece of work between South Tyneside Homes and Public Health. And we've entitled it Happy and Healthy Homes. And the project is ultimately about tenancy sustainment, but it was a good example of positively exploiting opportunities to engage with our partners around health and wellbeing. So just to set it into context, I guess the transfer of public health from the NHS to local government did give us a unique opportunity to move away from treating sickness to actively promoting health and wellbeing. And I guess what we mean by whole council public health is embedding public health across the council, whether that's through everyday interactions, by the wider public health workforce, right through to policy and strategy. So some examples of work already undertaken are children's centre staff delivering stop smoking services to pregnant women and their families, but also public health approaches to gambling, alcohol licensing policies, and using these as an opportunity to share the evidence of the impact on the most vulnerable and sharing evidence on what works, etc. And we in South Tyneside do have many areas of high deprivation, along with a high number of health inequalities. But we know, I guess from a housing point of view, our neighbourhood officers have access to some of the most vulnerable people. So a new approach to targeted visits, along with making every contact count, we feel will equip them with the skills to identify opportunities to help tenants to access appropriate services, with the backdrop of maintaining their tenancy, but also improved health outcomes. So for all the health and wellbeing challenges we do continue to face in South Tyneside, whether that's life-limiting illnesses, drinking to excess levels, or smoking during pregnancy or an unhealthy weight, we can also look to our fantastic assets in South Tyneside for them to be part of the solution to addressing our health challenges in a positive way. So the concept we feel of assets goes beyond the state of our buildings and regeneration initiatives that we have in South Tyneside. So we have town centre regeneration, we've got the opening of new state-of-the-art leisure centres, and as important as they are, which is great, but the assets are also about our local residents, the voluntary sector groups, and wider public health workforce who we know have the skills and abilities, but also energy to contribute to local community activity, and therefore extending the reach of some of our statutory services. The neighbourhood officers are indeed one of the key assets to South Tyneside, wearing many different hats, from social work, counsellors, a shoulder to cry on in many instances. They have daily contact with some of the most challenging and vulnerable members within our community, and we very much see them as part of the wider public health workforce. So the Tenancy Support Transformational Programme, South Tyneside Homes wanted to move away from delivering a real resource-intensive 18,000 visits over a 3-year period to a much more focused programme, and actually targeting the resource where it's much needed. And whilst the tenancy support visits predominantly do look at introductory tenancies and also streamlining the current process, they are also looking at key targeted groups. So decent homes, mop-up addresses, we have somewhat 960 decent home refusers, and we know that having this work carried out can improve an individual's health and wellbeing. And findings from initial high-rise work we done, I think it was back in 2013 now, some of the outcomes from that work I'll just share. So people had an increased feeling of positivity to their homes and suffered less stress, more social interaction and less social isolation as residents invited people around. Homes were warmer and heating costs had reduced, and the environment viewed as safer and less likely to incur falls or slips and trips. A reduction in smoking to prevent discoloration from newly papered or painted interiors, but also increasing in cooking, fresh ingredients from scratch because some of the kitchens were improved. So other targeted groups that South Tyneside Homes are looking at are gas-capped properties, repairs where they've had no answers in a set period of time. I think it's in the previous 3 years where we would naturally feel some repairs would be required. Hot repairs, this is where we have individual tenants over-reporting of repairs, not sort of outside of the expected reporting of repairs. Tenants over 75, tenants under 25, and others. We would include in those targeted groups any referrals from what we call our operational tenancy sustainment group, so people that may be an area of concern. So what we did, Public Health supported South Tyneside Homes to deliver a training programme to all neighbourhood officers, their area managers, but also their housing and health teams. And in preparation for that, staff were asked what mattered to them. So the detail I'll cover in the next slide, but the training actually looked at the current approach to tenancy support visits, and actually feedback from the current working practices was that it was unmanageable, outcomes were not being captured, and customer information was not used to target resources in the right way. And I guess there was very much a consensus from staff that a change of approach was needed, obviously not only from a capacity issue, but to recognise the importance of health, housing and education. So through the training we shared the CITRA work, which was carried out back in 2015, and that clearly demonstrated the role that housing staff can play in achieving broad public health outcomes. And the training was really a great opportunity to share with the staff what support, advice and information services were available locally to refer and signpost to. So that would include our social care single point of contact, but also our health improvement service. And there's other obvious services as well around safeguarding, but also access to practical procedures and also monitoring of outcomes. We also shared the vision of the Happy and Healthy Homes work, and this is working together to make South Tyneside the place that people are proud to call home. And we also looked at and explored the potential positive impact for tenants through this work. So it wasn't just around paying their rent on time, the practical elements. It was actually looking at improved mental and physical health and well-being, as well as improved social networks. So going back to the question, what matters to you? This is what the housing officers came up with. And as you can see, there's a whole raft of information there, but what was reassuring to see was tenants' well-being, trust and relationships were all up there. Like I say, not just rent being paid and clean and tidy estates. But in addition, staff were also asked about the challenges they face and going about their day-to-day job, because what we wanted this training to do was highlight any areas that we needed to build on in terms of skills and capacity. So many of these were operational issues that would have been resolved through the transformation programme, because these included things like lack of communication within teams, different teams have different priorities, too much administration, extra tasks and meetings to attend. And I guess staff were also aware of the level of financial hardship and the potential impact of universal credit and the welfare reforms. So from our point of view, it was really more imperative that workers knew where support services are and what services are on offer. So it is very early days. We have delivered 7 joint training sessions, and the feedback from the sessions have been really positive. Reassuring to hear about the new approach to these visits, staff having the tools to be able to have healthy chats and be able to signpost to relevant services confidently. We've got about 6 months worth of data now, which we're supporting South Tyneside Homes to develop into measurable outcomes, not only from a tenancy sustainment point of view, but public health outcomes point of view. So I'm now going to hand over to Stephen, who will go through the next steps and further opportunities.
Okay, hello everyone. Thanks very much, Wendy. I'm sure you'll all agree and heard there that obviously there's been a huge raft of work going on, particularly in terms of how we've built some relationships with our housing colleagues. And I think obviously that's enabled me coming in to really kind of think about what ways we can actually build on that. I think of some key next steps, particularly in relation to smoking, as I've now taken the tobacco control lead over from Wendy in the last 6 months. So I guess one of the key aspects of this is around how we ensure and support South Tyneside homes to build on the MEC approach, the Making Every Contact Count agenda, thinking about how we actually increase the skills within the toolbox of those staff to have those healthy conversations and chats. And I think certainly Abby's going to go on to talk a little bit more about very brief advice and how that will play a role in terms of boosting delivery of some of those key messages out into our communities. So that's certainly a key agenda for us, particularly around smoking, but also the wider public health agenda that Wendy touched on. So thinking about, their role in terms of alcohol harm reduction, drugs, substance misuse, mental health, etc. So there's a number of different kind of avenues that we're looking at, but I'm going to specifically focus on the smoking aspects for the last couple of minutes. Wendy mentioned also about how we monitor and evaluate this new way of working. So it's been about 6 months since this new approach has been introduced. And obviously we're looking at the kind of baseline data that we gather and support the development of some key outcomes, particularly around kind of the reasons for people refusing decent homes work is a bit of a concern for us, and people's health, socioeconomic status and age have a particular kind of impact on that. So that's something which will require some further investigating as well for us to understand some of the reasons behind that and work with the communities to improve their homes and in turn their lifestyles. And that links with how we will obviously review and report on those outcomes and measure the impact of this new way of working moving forward. Something that's particularly key and a significant piece of work for me is around the stop smoking service redesign. So we're in the process at the moment of reviewing and redesigning our stop smoking service offer, and certainly it was very interesting hearing from Lee earlier as well about some of the kind of plans and approaches that they're taking. So I'll say a little bit more about how we've kind of learned from some of the work that's gone elsewhere, in particular over at Greater Manchester. But alongside that, we've also held a really constructive and specific focus group with our colleagues in housing. I think Wendy mentioned that we really built those relationships with staff now, and it's enabled us to have a much more constructive conversation of way of working. So we held a specific focus group to look at the outcomes and the recommendations from the Smoking in the Home report, and think about ways in which we can actually improve on some of the recommendations within that report as well. We still have a really significant local ambition to reach that 5% prevalence rate by 2025, which is also alluded to in the National Tobacco Delivery Plan, and our Tobacco Office Fresh North East as well have the same kind of priority and ambition to achieve. Again, it's a very steep and kind of aspirational target. We still have some way to go. Our current prevalence in South Tyneside is about 18.4%. But we've seen some significant reductions in terms of our smoking time of delivery rates recently as well, which we feel is going to have a key impact. And it's a local ambition that we're still hoping to achieve and move forward with. And this is really an opportunity to build on further joint working, which resulted in the key actions that I'll just summarise with. So, as I mentioned, I think one of the key things is around how we improve information support and guidance for our kind of wider customers and service users and community, but also support and skills within staff as well, particularly thinking about how we can provide some more bespoke support and training. So we've been having some discussions as part of that focus group around how we can better include further advice, guidance and support about stop smoking support that's available through tenancy information packs. And we know that many private landlords impose smoking bans as part of tenancy agreements, but it's not something that's necessarily been explored or we're thinking about as part of social housing at the moment. But perhaps in terms of new developments, I think one of the recommendations of the Smoking in the Home report touched on and kind of provided some guidance around how we can provide further support and guidance and think about ways that we can limit smoking among kind of new housing developments. So that's something that we've been discussing as part of that focus group. But also providing our housing staff with the research and the evidence base and the support and guidance around some of the behavioural kind of impacts of smoking, what makes people quit, what the benefits would be, where those teachable moments are, and the kind of time frame benefits to quitting and the financial benefits to quitting smoking as well, which will hopefully help to support quit attempts and stimulate those positive, productive conversations that we hope our housing staff are well placed to have. I've mentioned there in the slides that we are exploring an e-cigarette kind of voucher scheme, incentive scheme, a little bit like the Salix Homes example. So, that's been really interesting to hear from. And again, that's an example that we're looking at closely in terms of how we can develop something similar in South Tyneside, particularly targeting some of our Housing Plus elderly care schemes as well. And that's going to be a key piece of work moving forward in terms of how we can build on the evidence base around e-cigarettes and support people to quit more effectively as well. But also we kind of recognise the insight and the intelligence that our housing teams have as well. So we're thinking about how we can bring together our intelligence and our data sets more effectively to target specific housing schemes more effectively in areas where we know there's been breaches of the smoking legislation, so smoking indoors, smoking in shared communal areas, illegal and illicit tobacco use, and linking to the national campaign around illegal and illicit tobacco, the Keep It Out campaign. So again, that's something that we're looking to work much more closely with our housing teams and colleagues around to think about how we can better kind of build upon the insight and intelligence that we have really around examples of where illegal and illicit tobacco use might be particularly higher in social housing schemes. And as I mentioned about those breaches of kind of smoking indoors, etc. as well. And finally, we're just kind of using the Smoking in the Home report recommendations to help kind of, benchmark ourselves to some extent in terms of, where the key gaps are and where those recommendations give us opportunities to work more effectively with housing colleagues as well. So we're looking at the report recommendations and looking at the areas where we're performing well and those areas where we've got key gaps. And just think about ways that we can actually build on that work moving forward as well. And as I say, particularly targeting certain housing schemes, we've also got insight and intelligence around kind of tobacco-related litter as well, and where can we actually utilise and support some of those communities more effectively in terms of provision of information and support, where we know we've got those hotspots and areas to target and build upon some of those national and local campaigns as well around stop smoking awareness, such as No Smoking Day on the Horizon, and obviously the National Stoptober campaign as well, in conjunction with Fresh North East as the kind of regional tobacco office as well. So I think that kind of summarises everything that Wendy and I wanted to kind of put forward from a South Tyneside point of view. We've included our email addresses there, and obviously we're happy to take questions at the end of the webinar as well.
Thank you, Steve, and thank you, Wendy. That was really interesting, and I'm sure hopefully we'll have time for a few questions at the end, but we are running a little bit over. So I will move with no further ado to our last two very swift presentations. And we've been talking a lot about the role of different kinds of landlords and housing in particular in the last few presentations. And now we want to move on to briefly talk about the role of some of the wider professional groups who are going into people's homes and where there's a real opportunity to kind of take further action around delivering brief advice. So Abby Enoch is joining us from Hackney Council to talk about the role of health visiting on this agenda. So Abby, over to you.
Okay, thank you. Hi, everyone. So today I'll be talking to you about our work with health visitors to promote smoke-free homes in Hackney. So why work with health visitors on this? Guidance highlights the role of health visitors in supporting smoking cessation in pregnancy and postpartum, including Public Health England's health visiting program pathway to support professional practice and deliver new service offer, NICE Guidance PH26, and various others, although often more emphasis is placed on the smoking and pregnancy stage. Health visitors are a trusted health professional who are likely to already have a good relationship with their client and feel comfortable talking to the woman about her behaviors and home life. They're qualified nurses with a public health role. They already do home visits and do assessments of the home environment. Also, this is a good time to target these women, as having a baby or a young child in the home can be a powerful motivation for having a smoke-free home. And women will already have been asked about smoking by midwives during antenatal appointments, and so they expect to be asked by the health visitors. So in Hackney, we decided to add a KPI to the health visiting specification that requires health visitors to ask women about their smoking status at the new birth visit, with a target of 95% of women. Then in February 2017, once a CO monitor had been procured by health visiting for each of their teams, training was given to the health visitors on very brief advice, focusing on having the conversation, giving a CO test, and the dangers of secondhand smoke. But CO monitors weren't used consistently when only one was available per team, so more recently, enough CO monitors were bought for each health visitor to receive their own. There were issues with quite a few of these being faulty, though, some probably faulty when delivered, others may not have been handled correctly, but now each health visitor should have their own CO monitor. And CO monitors are particularly useful because not only are they more accurate than self-reporting smoking status, but they show an elevated score if the woman has been exposed to secondhand smoke. So that helps to show her evidence of the effects of secondhand smoke. And we also have a smoking in pregnancy and after childbirth task and finish group, which helps to coordinate and monitor the work of health visitors and other health professionals in helping to reduce smoking in pregnancy and postpartum. So health visitors now ask all women at the new birth visit about whether they smoke, and having the smoking KPI and the task and finish groups have helped to drive this. And at the moment, 46% of women are CO screened at the new birth visit. So if a woman says she's a smoker, or if she gets a high CO reading, then the health visitor talks to them about the harms of secondhand smoke exposure and the benefits of having a smoke-free home. And this is part of a wider discussion on smoking. The health visitor then asks if the woman wants to be referred into our Stop Smoking service. And the health visitor also asks if the woman's partner or anyone else in the household smokes. And if they do, then this information should be recorded. And if they're present at the appointment, then the health visitor explains the risks to them and offers referral as well. And while health visitors have training on smoking as part of their general internal training, they haven't had a specific training on promoting smoke-free homes since the training I mentioned before in 2017. So in terms of future plans, health visiting is working on increasing the proportion of women who are CO screened with the aim to do a CO test with each woman, preferably at the new birth visit or otherwise at the second appointment, which is the 6 to 8 week check. And health visiting reports on this at the task and finish group meetings, and these meetings also help to provide a strategic steer to these efforts. Also, our Stop Smoking service is currently developing a tailored, very brief advice training for health visitors to provide a more standardized, comprehensive, and fit-for-purpose set of knowledge and skills surrounding secondhand smoke VBA for the health visiting context. And this will be a train-the-trainer training and will include information on the general principles of VBA within the smoke-free homes context. So this will include asking about whether the woman or anyone living in or regularly visiting the home smokes, where they smoke, if rules on where they can smoke are ever relaxed, advising on the harms of secondhand smoke exposure, particularly the risks for babies and young children, helping to refer smokers into the local Stop Smoking service, or if they can't or don't want to quit yet, then providing practical support and help to not smoke in the house. For instance, talking to them about going outside, using NRT or vaping, and also talking through barriers the women may face in keeping their home smoke-free and tapping into their motivations for wanting a smoke-free home. And the training will also discuss barriers health visitors may feel could prevent them from providing VBA. So, for example, if they feel that talking about smoking will disrupt their relationship with their client, or if they feel that they don't have time to have these discussions. And finally, the training will also cover how to use CO monitors. There are some areas relevant for the training that are still being discussed and thought through, though. For example, it's important for smoke-free homes to be discussed more than once with the women, but health visitors have limited time to cover many topics, so it's important to really think practically about when and what they can say. It would also be helpful for the training to talk through how health visitors can recommend that the postpartum woman talks to others in the household who smoke about them helping to create a smoke-free home. And it's important to consider how much knowledge on e-cigarettes health visitors should be expected to have. It's also important to ensure that the referral pathway into the Stop Smoking service is clear and effective. And then finally, feedback mechanisms are also being set up and strengthened between maternity and health visiting and between Stop Smoking service and health visiting. so that health visitors have information on the previous smoking status of the women, any referrals or quit attempts, etc., which can help to facilitate these discussions. And this is being coordinated through the Task and Finish group. And finally, health visitors also reported that they often don't get information on smoking status in the discharge papers for women who received antenatal care out of borough. So we've met with relevant representatives from nearby trusts and local authorities to discuss how we can better share these data across boroughs. That's it. Thank you.
Thanks, Abby. That was excellent. We are tight for time, so we're going to move on to Phil because we definitely want to hear from him. So Phil has joined us on his annual leave, so we're incredibly grateful, and also from Merseyside and Fire Rescue Service. And Phil is going to talk to us about the role which the fire service can play in delivering brief advice in people's homes. Phil, I'll hand over to you.
Good morning, everyone. I'm Station Manager Phil Hart here from Merseyside Fire and Rescue Service. I'm the Home Safety Manager in Community Fire Prevention. And I'm going to talk about the opportunities for the Fire and Rescue Service to support smoke-free homes. I only have 5 minutes, so I'll try my best to cover the relevant points. So first of all, why are the Fire and Rescue Service here? So recommendation 8 within the smoke-free home housing report. And recommendation 8 talks about standardised the approach of fire safety to reduce smoking in the home. It's available there for you all to read, but obviously this is where it links in with the Fire and Rescue Service, so I won't go into too much extra detail. And why are we interested? So if you look at fire fatalities in England since 2010, it's clear why smoke-free homes is on our agenda. So 36% of fire fatalities since 2010 are from smoking materials. And if we break that down over the years, if you look at the breakdown from the year on the year, fire fatalities are consistent, and with the red numbers being the fire fatalities, so you can see it is quite consistent in terms of the figures that you get on the fatalities every year. What has Merseyside Fire and Rescue been doing since 2019? So the Fire and Rescue Service Act 2004 created the statutory duty on fire and rescue authorities to continue to promote fire safety placing the prevention of fire and health of their activity at the heart of their activities. So we've been focusing on delivering home fire safety checks throughout that time. Now can the Fire and Rescue Service help? Our home fire safety check. Discuss nighttime routines and individual escape plans by fitting smoke alarms and cover individual needs such as hard of hearing smoke alarms. Issue fire service interventions where required and work within signposting to relevant partner agencies. And we also have now links with the self and well visits that we conduct. Safe and well visits provide an opportunity to reach people who may not engage with health interventions, especially those who are more vulnerable. Fire and Rescue Service is a natural partner for health. English Fire and Rescue Service deliver as many as 670,000 fire safety interventions in people's homes every year. Our brand and our steering gives us access to people's homes that others cannot achieve. In recent years, a number of fire and rescue services have begun to work more closely with health and local authorities. And where we are at the moment within Merseyside, so smoke-free homes progress in Liverpool, partnership work between Public Health, Merseyside Fire and Rescue Service and South Liverpool Homes. So Public Health develops a rationale for the development of smoke-free homes interventions in Liverpool, which include the case for fire safety. Health and Wellbeing Boards approved the proposal to develop a smoke-free homes programme in Liverpool in September 2018. And smoke-free homes workshops held with housing association staff and stakeholder partners, including Merseyside Fire and Rescue Service, Merseycare and Liverpool CCG. Following discussions with Merseyside Fire and Rescue Service and South Liverpool Homes, Public Health prepared a paper outlining the process for introduction of the smoke-free homes policy and the contribution of key partners. All partners are now working towards a launch of smoke-free homes in the summer of 2019. The main reason why summer of 2019, you're going to see more people are more likely to want to smoke outside than inside when it's colder. South Liverpool Homes will work through the process of developing a new policy, consulting with staff and then tenants, and developing a baseline for household smoking. Merseyside Fire and Rescue Service are working to identify vulnerable residents, incorporating smoke-free home key messages into the home, fire safety and safe and well visits. Merseyside Fire and Rescue Service will attend a smoke-free homes themed walkabout Wednesday with fire engines visiting tenants' home to offer advice to the risk of fires caused by smoking in the home. Smoke-free Liverpool Stop Smoking Service will develop additional access points for the services and provides one-to-one home-based support for pregnant women and their partners. And with this, we could also start using some of our fire stations, which also have community facilities. Merseyside Fire and Rescue Service will deliver stop smoking brief advice and refer residents to Smoke-Free Liverpool for help to quit. Public Health are currently exploring options for the evaluation of our Smoke-Free Homes programme, supported by Merseyside Fire and Rescue Service business. Thank you for listening. I know it was very quick there, but I know it was short of time. It was a quick 5 minutes, so thank you for listening.
Phil, thank you enormously for your quick canter through that. We, due to my failure to chair properly, we do only have a few minutes left for questions. I've got one for you particularly, Phil, around engaging with older smokers. So somebody from another fire service, I think, saying that they note that people who are over 60 are more likely to be the victims of fire fatalities in relation to smoking. So how you might go about engaging these older smokers who have a much more ingrained addiction. If you have a quick answer to that at all.
Yes, certainly. What we do within the fire, Merseyside is one of the first ones to use extra data, which is NHS data in terms of number of interactions they might have used with the health service. A lot of this might be over 65s who also smoke and also might have other health issues. So Merseyside Fire and Rescue Service will take that in and we'll use more of our specialist teams to go out to them, older smokers with other health problems, and we'll target them by spending more time with them. The teams are more specialised in terms of the advice that they can give and also how they can persuade them into quitting smoking or going to the actual the quitting services of the area.
Brilliant. Thanks, Phil. So, Sarah, a quick specific question for you as well about whether you've looked at the data in relation to the private rented sector and compared that to social housing at all.
No, we didn't specifically. I think at one point we did compare each category individually to social housing and found the same results, but we didn't present anything separately for the different housing tenures.
So there's a difference between people living in socially rented sector compared to the private sector, but you haven't compared the private sector, for example, with people in owner occupied.
No, I mean, from memory, the results that we found for social housing compared to every other housing tenure held up when you split them into different types rather than grouping them together.
Yeah. Thank you. Right, we don't have time to answer all the questions that you asked, unfortunately, and what we will do is do some written responses to some of the really interesting questions that have been asked, particularly around e-cigarettes, where we can, I think, provide some more detailed background information. I just want to ask some of you on the line if you could just offer a little bit of advice for organisations who are hoping to engage with your organisation, or your type of organisation in relation to smoking. Lee, what advice you might offer to public health if they're looking to engage with a housing organisation like yours? What would be your advice on making that first approach?
Pick up the phone or find out who's engaged within the local community, I would say. I'm a member of Salford's Health and Wellbeing Board, and that's a really good link into the health community. But if health colleagues wanted to engage with housing, a really good place to start would be each local authority tends to have a housing partnership, which sort of oversees and is consulted on on housing policy in the area. That will tend to have representatives from a whole range of housing providers. So I would go to the local authority and seek out the housing partnership in that area you want to work with, and go and knock on the door and go and ask for an invite.
Brilliant. Any last tips from Wendy and Steve as well before we run over our time and turn into pumpkins?
I think just to echo what Lee said, but from a public health point of view, it's actually talk to people. Certainly in South Tyneside, we have absolutely pushed on an open door with our colleagues across housing and the wider partners. We're ultimately there for the same aim. We might take a different journey to get there, but actually by opening up the dialogue and having the conversation, you can work through some of the sometimes complex systems. So, Stephen, I don't know if you've got...
Yeah, no, I would totally echo that. I think in the bit of time I've been in South Tyneside over the last 6 months, I've noticed that, the relationships, the work that Wendy's done to establish those kind of links and those shared priorities and objectives with housing has been really clear, really obvious. So again, it has been like pushing an open door. But I would just say to everyone that, yeah, if you can establish that kind of shared objective and vision, as you say, we're all in there for, supporting the well-being and the welfare of the wider community. So it is just very much about how we actually reach that overall point, really. So having that shared overarching objective and some clear, tangible actions which we all signed up to is going to be really key.
So it is good to talk, but not too much, as we have run out of time. So we will provide some responses to some of the questions that you've asked. And if you have any further ones, then do email us and let us know. Just to remind you that the webinar will be available for download, so you can share with colleagues. And we'll be following up as well some of the comments that you have made to us. So thanks to all our presenters today for your fabulous presentations. And I'm sorry that we didn't have time for more questions.
Thank you. Thank you all.
Thank you.
Thank you. Bye.
Thank you.